Good afternoon. My name is Mary Wood. I'm the FAS of the Population Health Division. I would like to acknowledge the traditional owners and custodians of the land in which we meet this week for the Policy Symposium. For many of us in the department, we meet on Ngunnawal land. I would like to pay my respects to elders past, present and emerging, and extend my respects to any Aboriginal and Torres Strait Islander people here today. I'm really pleased to welcome you to the Australian Longitudinal Study on Women's Health Policy Symposium, with lunchtime presentations scheduled daily for the rest of this week. The Australian Longitudinal Study on Women's Health has been providing data on the health of Australian women since 1995. The study continues to provide valuable data to government and decision-making bodies within Australia to improve health outcomes for women and girls. The study assists the department with topical areas, providing unique insight into women's health across the life course, including reproductive health matters such as contraception, conception and change of life. We have a really rich agenda for this week's presentations, which will cover key priority areas of the National Women's Health Strategy 2020 to 2030. Today's session will cover insights from the longitudinal study in relation to risk factors for health and wellbeing in midlife. Tuesday, we'll focus on endometriosis and IVF. Wednesday, we'll explore mental health and COVID-19 vaccine hesitancy. Then on Thursday, the presentation will be on the impacts of violence against women. And Friday, we'll focus on something we can all aspire to, healthy ageing and longevity to 100 years. I would like to thank Professors Gita Mishra and Julie Biles, the directors of the study, and their teams for organising this week's presentations and for their fruitful collaboration with the department. We do hope the sessions will provide opportunities to continue to build relationships, to exchange ideas and priorities, and to ensure the study can continue to respond to our data needs and contribute to policy development across government. I will now hand over to Gita and Julie to introduce the study and start today's presentation.
Good afternoon, everyone. I acknowledge the traditional owners of the land on which we meet today and pay my respects to their elders, past, present, and emerging. I extend this acknowledgement to the Turrbal and Yagara people of the land on which we are speaking and to all the many peoples of the lands on which we live and work. Today I'm going to get the symposium going with a brief overview of the Australian Longitudinal Study on Women's Health. And first, I would like to thank the Department of Health for their funding and commitment to this study, and for giving us the opportunity to present some of the latest results on women's health. And I thank my colleagues in Canberra, Newcastle, and Brisbane who have made this symposium possible. The study has been funded by the Australian Government Department of Health since 1995. This year, we're celebrating the 25th anniversary of when the baseline surveys were launched. The main purpose of the study is to provide the evidence base for the development and evaluation of policy and practice in the areas of service delivery for women. It also aims to provide an accurate picture of health and well-being of women in Australia and to examine factors that determine good health and those which cause ill health through adult life. The study is jointly conducted by the University of Queensland and the University of Newcastle. ALSWH is one of the largest and longest running studies of its kind. In 1996, 3 aged cohorts were recruited. Those born in 1973-78, they were aged 18 to 23 in 1996. Those born in 1946-51, they were aged 45 to 50 years. And the 1921-26 cohorts, they were aged 70 to 75 years. When the study started, each cohort represented women at an important life stage. The 1973-78 cohort were moving from education into employment and family formation. They're now in their mid-40s. The 1946-51 cohort represented women at the end of their reproductive life stage. They're now in their 70s. And the 1921-26 cohort were in post-retirement life, and those still with us are now aged 95 to 100 years. The sampling frame for these cohorts was the Medicare Australia database. The map shows the distribution of area of residence for all participants where women from rural and remote areas were oversampled. Overall, these cohorts were broadly representative of the population at the time of recruitment. There have been two major developments for the study. First, after 17 years, the 1973-78 cohorts were no longer young adults, but entering midlife. So to collect information on the health and well-being of current young women, we were funded in 2012 to recruit a new cohort of women aged 18 to 23, known as the 1989-95 cohort. This time, recruitment was done entirely via social media. Second, in 2016, the NHMRC funded the Mothers and Their Children Health Study, or MATCH, which is a study of all children born to women in the 1973-78 cohort. This is the next generation, with 6,000 children in the MATCH study, and a majority of them now are adolescent. This table shows the number of waves for each cohort. The oldest women have completed their 18th six-monthly survey. Survey 9 for the 1973-78 cohort, when women are between 43 to 48 years, is now in the field. In addition to the survey data, which includes repeat data on health behaviors and health and well-being measures, we have a rich array of data to use. First, on the last page of each survey, women are given the opportunity to inform us of anything we have missed. So far, more than 30,000 women have provided qualitative data. This can provide both new topics to investigate and also the context for responses to the survey questions. More recently, ALSWH datasets have been enriched with the inclusion of environmental data, namely with green space and air pollution metrics. We also have a major data linkage program. It is a substantial and complex undertaking, partnering with data custodians. Being a national study, we link with national collections such as with PBS, MBS, and aged care databases. These are done on an annual basis. State collections, such as perinatal data and hospital data, are linked probabilistically by the relevant data linkage units. For each new linkage round, we send through the participant list, including all known changes of name or address. Processing times for probabilistic linkage tend to be a bit longer, so we aim to update these collections every 2 years. Records for children in the Mothers and the Children Health Study are linked to state and national education collections, and this is obviously done with maternal consent. I'm also delighted to say that this year we are embarking on a new project to refresh the study samples of the 2 youngest cohorts of women, with women from Northeast, South, and Southeast Asia. One of the key aims of ALSWH is to provide an evidence base to underpin women's health policies. To do this effectively, our participants need to be representative of the Australian population. Australia has experienced extensive immigration over the last 2 decades, particularly from parts of Asia. So it is time to improve the representativeness of the study for these groups of women. The purple-colored bar shows the percentage of women in the 1973-78 cohort by region of birth in 2015, when they were aged 38 to 43 years. This is compared with same-aged women from the 2016 Australian census. You can see that ALSWH participants are predominantly Australian-born, and the Asian-born women in particular are underrepresented. So here we're looking at a figure of 1.6% in ALSWH versus 15.5% in the population. So we have received funding to recruit 1,000 women from Asia for each of the 2 youngest cohorts, which will increase the cohorts by about 10%. To bring these women into the studies, we have been busy working with community groups to ensure that we have appropriate methods and effective strategies in place before recruitment begins in January next year. These include cultural consultations, ethics, assessing recruitment strategies, and producing targeted materials from posters to social media posts and videos. I'll show an example of the video at the end of this talk. We also continue to work on improving the operation and impact of the study. This includes the updated ALSWH website with improved access to information on the study and publications for both public and researchers. We are also continuing to facilitate researchers to work on new projects and topics using ALSWH data. So we have a light option where basic anonymized survey data can be accessed relatively quickly from the Australian Data Archive. Full data sets, plus or minus linked data, are only available by direct application to ALSWH. We have a new portal for managing applications, researchers, and publications for each project. ALSWH is also contributing on the Queensland Cyber Infrastructure Foundation to develop a secure e-research platform. Use of such platforms is now considered best practice for facilitating research using linked data. This collaboration will enhance cybersecurity and ensure that the new platform meets the needs of data custodians, ethics committees, the ALSWH Data Management Committee, and our research collaborators. The broad engagement with the research community to date has been an outstanding success. So far, around 1,500 researchers are using or have used ALSWH data on over 1,200 projects. 225 researchers are using or have used linked health record data. And there has been over 100 PhDs completed on the study, with 24 using linked data. The study has also resulted in over 1,000 peer-reviewed publications and reports, and that the number is rapidly growing on an upward trajectory as the study has developed. Another way to illustrate the extent of research impact directly based on ALSWH data is the number of recent and current funded research projects. Just to highlight 2 aspects, it includes the collections of new biomedical data such as blood samples and DNA from ALSWH women. And we've seen ALSWH data as a core contributor to major international collaboration on women's health. But each of these projects adding to the value of the study. We are doing this to ensure that we continue to produce robust and high-impact evidence. A prime example has been the contribution of the study to the evidence for the National Women's Health Strategy. But the National Strategy is just one of a long list of contributions to major health and policy guidelines. The findings from the study have also contributed to government inquiries on a range of topics. Looking ahead, we have a series of ALSWH deliverables. These include the major report on health and well-being for women in midlife, which Annette will present on next. But before I hand over to her, I would just like to play one of our cohort refresh videos.
Our study is funded by the Department of Health and run by the University of Queensland and the University of Newcastle. In 1996, we recruited women from all around Australia to tell us about their health and well-being. But Australia has changed a lot since then, with more women moving here from other countries. We'd like to recruit some of these women to our study so it better represents all Australian women. So who can join our study? We're looking for women who are from Northeast, Southern or Southeast Asia, who were born in 1973 to 1978 and have a Medicare card. You might be wondering, why is this research so important? It's because women tell us about all of their different health issues. This informs clinical practice and government policy, which translates into real change for Australian women. What do you say? Will you be part of it? Contact us now. We can't wait to hear from you.
Thank you for listening, everyone.
I'll just take very briefly a short question. Someone asked whether we need a university affiliation to access ALSWH data. The answer is no. And depending on how urgently you need it, if you need something short for a very as soon as possible, I encourage you to go to the website that will direct you to the Australian Data Archive, and usually the approval takes about less than a week. But if you do need more extensive data, then you'll have to put an expression of interest to the ALSWH Data Management Group, and we'll try our best to speed it up if you need it as soon as possible. There's only one question, really. Okay, so if you have any other questions, keep putting it in the poll EV, and we can address it at the end of Annette's presentation.
Hello, I'm Annette Dobson. I'm going to be sharing some of the findings in our report for this year. It's about women's health in midlife. I'll be looking at patterns over time for two groups of women. The cohort born in 1973 to 78, who were aged 18 to 23 in 1996 and are now aged 40 to 45, and the cohort born in 1946 to 51, who were aged 45 to 50 when the study began and are now aged 68 to 73. So these two cohorts nearly overlap across the age span. I'll be looking at similarities and differences in health-related behavior and risk factors, health conditions and the development of chronic disease, and the use of health services. Firstly, in the report, we've looked at women's adherence to guidelines. Smoking has decreased in both cohorts and is now below 10% among the younger women and below 5% in the older women. About 80% of women in both groups meet the definition for responsible drinking, but it wasn't always so. In 1996, about half the women aged 18 to 23 would not have met the guidelines, but over time their alcohol consumption has declined, so they now behave more like their mother's generation. About 60% of women currently meet the physical activity guidelines, but physical activity levels also change across the lifespan. For example, when the younger women reached their 30s and had young children, their leisure time physical activity decreased, but then it increased again later. Weight increased steadily over the time for both cohorts. Especially worrying is the increase in obesity among the younger cohort. This can be seen in the next video. The green area is for BMI less than 25, that is underweight and healthy weight. The yellow area is for overweight. The red area is for obesity. Across 8 three-yearly surveys, the prevalence of overweight and obesity increased from about 20% that you can see here to more than 55%. In the long term, the rapid increase in weight among women born in 1973-78 is likely to have consequences for their health and the development of chronic conditions. And I'll now be looking at these issues now. This graph shows age along the x-axis and the prevalence of diabetes on the y-axis. The blue line shows the trajectory for the younger cohort, and the green line shows that for the older cohort. And you can see that the rise in diabetes in the younger women means that at the next survey, when they'll be the same age as the older cohort were in 1996, their diabetes prevalence will be higher. If it continues to rise in parallel with the age-related increases experienced by the older cohort, it will impact severely on their health and the health services. This slide shows the percentage of women who rate their health as excellent or very good. Between the ages of about 20 and 30, the younger women began to rate their health higher, and it's only declined slightly at recent surveys. The older women's rating has been pretty stable over time. This is important. These self-rated subjective assessments of health integrate both physical and mental health. So it's also useful to look at these separately. Here are the mean health scores for mental health using the SF36 instrument. Mental health increases gradually with age. This finding is consistent across other measures. For example, measures of poorer mental health, such as depression, stress, and anxiety, all decrease with age. I should point out that these surveys were conducted before COVID, and later this week, the team will be talking about the impact of COVID on the study participants. Now let's look at physical health measures. This graph shows the prevalence of cancer increasing across the age groups. For a broad category of conditions, such as all cancers, the smoothness across the cohort is the dominant pattern. The blue and green lines follow a single trajectory. Another example of a common condition showing the same pattern is heart disease. Any effects of the higher levels of obesity in the younger cohort, which would result in the blue line tracking above the green one, may not be apparent for another 5 to 10 years. Arthritis and other chronic conditions follow this same pattern, but not everything does. Here's an exception: asthma. This is more common among the younger women, and while there's speculation that the difference is due to changes in diagnosis over time, much still remains to be explored. Now I'll look briefly at the use of health services. This graph shows the percentages of women who saw a specialist in a single year. As you'd expect, this increases with age for the older cohort. The slightly higher use among the younger cohort may also represent differences in service use across generations. This figure about hospital stays shows a spectacular life stage effect. When the younger cohort were in their 30s, they went to hospital to have babies. As the older cohort moved into their 60s and 70s, they went to hospital for procedures or due to ill health. Here's one more odd-looking graph. This is the rates of hysterectomy, showing how they changed dramatically over time. Hardly any of the younger cohort have had a hysterectomy, whereas by the age of about 50, more than 20% of the older cohort had had a hysterectomy. This is an example of changing forms of treatment. So in summary, there have been increases in some things, notably obesity in younger women, which is likely to lead to greater health problems in the future. Some things have improved, such as less cigarette smoking. Many factors change over the life course. Mental health improves, so does responsible use of alcohol. Most chronic conditions increase with age. In contrast, health services and practice can change over time because of different drivers. Treatment changes are one example, as in the hysterectomy rates. Diagnosis can also change, and this may explain at least some of the differences in asthma. So where does this leave us? We're now at a crucial point for the baby boomer women born in 1946 to 51. They're now in their early 70s. Should we be rethinking our approach to this cohort? Should we focus on continuity with the younger cohort and the even older women? Or should we change focus to more explicitly look at aging and aged care to monitor the effects of changes in policy and services, especially following the Royal Commission? Should we have shorter, more focused surveys or more frequent surveys? I'll leave you with those questions. Finally, I'd like to thank the Department of Health for funding the study. Also, the Universities of Newcastle and Queensland for supporting us, including their ethics committees who work hard for us. Then there are those involved in data access and linkage, including the data custodians and the linkage authorities. Most importantly, however, are the study participants. So thank you from the Newcastle team on the left and the Queensland team on the right. Thank you.
Hi, we have one question on my presentation, and that was about maternity health and geographic coverage. Yes, we've got masses of data on health before, during, and after pregnancy, and it's certainly at a sufficient level to look at quite fine geographic variations. It's not included in this particular presentation because I was trying to compare the 73-78 cohort and the 46 to 51 cohort. But yes, there's masses of data. And we have done a lot of analysis on it.
I think in the next few days, you'll hear some of the presentations that have utilized maternity data. So, yeah.
And I don't know whether the system will allow Deb Loxton to comment, but Deb in Newcastle has led a lot of the work on maternity and maternal health. It looks as though we can't get Deb in on that one, but I can assure you lots of data, lots of analysis, and plenty of coverage of cities and rural and remote areas.
Deb will be speaking on Wednesdays and Thursdays, so I'm sure she'll be able to speak a little bit about that.
Yeah.
Any other questions? I think it's mainly the maternity health.
Yes.
Factors. Yeah.
Yes. Okay.
Well, if you have any further questions, you're most welcome to send it to us through the emails on the website, or you can directly email myself or Annette or any members of the ALSWH team. So thank you.
Hi Gita, it's Deb here. I've finally been unmuted. Please forgive us, we're all a little bit unfamiliar with this system. I think we're all a bit Zoom addicted. We have a lot of data from perinatal data collections and also the admitted patients data collections. We've had students who've had a look at the impact of a neonatal near miss with infant data collected through the perinatal data collection, and an extensive body of work in postnatal depression and perinatal mental health using linked and survey data together. If there's something in particular you'd like to know, you could pop it in the chat, or feel free to get in touch with us after the session.
No, we've just been told there's one more question.
Yep, here. What do study
currently tell us about the experience of aged care in older cohort of women? Again, this wasn't in this presentation because the oldest cohort were born in 1921 to 26. They're the group who are now in their 90s. So a lot of them have experience with the aged care system. And we have in fact published widely on this, and Julie Biles will be talking about this on Friday. I guess the question that I was trying to raise was that now the group who used to be called the mid-age group are now in the early 70s. This is the group who are now going to be experiencing the changes, assuming that we do get good changes in the aged care system, will be in a position to see how they affect the current women moving into the aged care system, aged care support services. But Julie will be talking extensively about the much older women on Friday. Does that answer the question?
Good. All right, Julie. There's another question about rural women. So the question is, given the lack of resources for many rural women, how many have been included in the studies? You'll be glad to know that both the cohorts that were sampled in 1996, they were oversampled for rural and remote areas. So the numbers are sufficient to do a lot of the statistical analyses.
So, and indeed, you're absolutely right. One of the main issues about services is access to services. It's the very first thing you look at in any of our data. But as Gita said, you know, we've got they were sampled in double the proportions that they actually exist in the population. So we've got quite a lot of power. The other thing is that those cohorts actually haven't moved very much, perhaps surprisingly, but it means that we have retained participants in rural and remote areas really pretty extensively.
Another one.
Yeah. The oldest cohort, that's not the ones that, sorry, the question is, what do you see as the future of the study, noting the age of the oldest cohort? This is something Julie will be talking about on Friday. As said, that they're now in their 90s, and some of them have now received their birthday card for their 100th birthday. So it's a special cohort. These are people who've actually doing extremely well, and there are a lot of lessons that can be learnt from them. The other thing we should say is that for quite a few years now, we haven't been surveying them yearly, 3 yearly, but rather every 6 months, so that we're trying to do sort of near real-time a collection of data. And that does, it tends to be more about their health than their experiences with the health services. but nevertheless, we're able to monitor them quite closely.
The other thing to add to this is that the 1946-51 cohort now will be stepping into the position of the 1921-26 cohort.
Yeah.
So they'll be the early older group that we'll be looking at. But the other thing also with respect to the study then is that we'll be thinking about the younger cohorts as well, because the 18 to 23 years old who are that age in 2013 are now in their late 20s, early 30s. So we've been thinking about how we can get another cohort of the so-called the new young cohort, aged between 18 to 23 into the study. So that's something that we're all thinking about.
Yeah, I mean, one of the issues here is how the environment, particularly the environment for services, changes. As I showed you, some of the patterns are so strongly life stage dependent that, you know, we can pretty much guarantee that the younger women are going to follow a similar pattern to the previous generations. That's the interesting issue about aged care, because if that changes fairly dramatically, it'll be important to be able to identify that and feed that into the department and everyone else who's interested. There's another question here. Are there any plans to reach even younger women? And absolutely, yes. And the second part is the impact of COVID-19 seems to be significant at all ages, but especially young women. Absolutely. And that's what Deb Loxton's going to be talking about later on. That there definitely are cohort differences in responses to COVID. We found that. Everybody else who's been doing surveys of people's reactions to COVID and lockdowns have found the same thing.
This is the
gut microbiome. Yeah. Over to you, Gita.
Yeah, so look, we have tried to get at least a gut microbiome sample for the children in the match study. Let's put it this way, it is really difficult to collect stool samples, especially when the samples are, you know, the children are all over Australia. So it's certainly something that we might explore in the future. We might just look at, you know, randomly sample people from different areas and try and do it. But it is very expensive, extremely expensive to collect biological data and then to be able to process it. So we are aware of it, but yeah, we haven't got the money or funding to do that sort of work. Thank you. Any other questions?
Guess we'll all meet again tomorrow.
Yep. Early lunch. Okay, based on the data, what has been the biggest health challenge for women in 2021?
That's going to depend a lot on perspectives. I mean, of course, COVID is important. And as I say, Deb will be talking extensively about this on Wednesday. The other thing, of course, is the issue that's affecting particularly the younger women, and that is the rise in obesity. And even the behavior changes during COVID may well have exacerbated that. This is a massive health problem for Australia. And of course, the Royal Commission into, broadly speaking, into aged care. The long-term one hopes that that's going to have a substantial impact. At this stage, it's a bit up in the air yet, shall we say.
What about mental health? I think that's a big issue.
Yeah, well, that's what Deb will bring up
Yeah.
in the discussions about COVID.
Yeah, so mental health is definitely
Yep.
one of the biggest challenge, I think. Mm. Thank you very much, everyone. Thank you for listening, and we will meet again next week. Oh, no, tomorrow.
Yes.
Next week. Tomorrow. Thank you.